All right, y'all. Um, without further ado, I'm going to introduce our speaker for tonight. And many of you know him, but Dr. Jody Buckwalter is one of I have somebody I've been friends with actually for quite some time now, since we were back residents going to Mid-America way back in the day. It seems like at this point, and now in travel club and everything else. So have kind of parallel lives to this point, but. It's sort of my honor to introduce y'all to him. He's going to be talking today about DRJ arthritis in general, and then DRJ arthroplasties and kind of his experience with this. For a background, he has a, very similar type of referral practice that I and many of our colleagues here at Emory have, and really serves as an expert in the Midwest and somebody who has built a really incredible upper extremity practice and has very, very cool things ahead of him. So it's going to be fun to sort of continue to parallel our careers together. So, Jody, thank you very much for joining us, and the floor is yours. And then whenever you want, just let us know, and we'll open up to questions.
Okay, fantastic. I'll just start by thanking Eric. That's a wonderful introduction. We have known each other for quite a while now. I tried to get him to come to Iowa at some point, so maybe that's still in the future. But I really appreciate the opportunity. I'm going to try to share my screen here. Let's see. So, so can you all see my screen?
We can't. Yeah.
You can see it or
Yeah.
cannot?
Yeah. There you go. Hurt. Yes. Yeah. That hurt.
Okay, so fantastic. So as Eric said, my name is Joseph Buckwalter. I go by Jody, so you're welcome to call me Jody. I'm a hand and upper extremity surgeon at the University of Iowa. Eric and I are the same year, so we've been practicing about the same amount of time. And as Eric mentioned, my practice is quite broad. I do really almost everything, pediatrics, complex reconstruction, elbow, wrist, hand, trauma. I just had an OR today, and I really did a mix of everything. And it's been a pleasure to practice in this kind of big referral pattern. And I'm sure it's very similar to the things you see down in Atlanta. I thought when Eric asked me to do this, I picked a topic that I thought is interesting and something that we don't get to do all that often. I find that these types of opportunities really to talk about something unique and really maybe open up the discussion and talk about what people are doing for this might be interesting. So I chose DRUJ arthroplasty. And as Eric mentioned, I'll touch a bit on arthritis in general and some of the other treatment options, but try to focus on arthroplasty and some of the techniques we use for this. I think it's pretty cool, and I've had some pretty good experiences and some pretty not so good experiences. So I thought it'd be nice to share this with you all. I've put the talk together for about half an hour or so. So hopefully I can just talk. I can't see you all right now. So if for some reason you have a question, go ahead and I don't know, do something. Let me know. Just ask. And I'll go ahead and I'll stop the talk. Sorry. So I have no disclosures related to this talk. This is our new building actually right here on the right. I was just talking with Eric about it. Um, let's see. So the presentation outline, I'm just going to give you a brief introduction of arthritis, the anatomy and mechanics of the DRUJ. I have three cases I'd like to present. I'm going to just introduce them briefly and then talk about them later towards the end of the presentation. I'm going to talk about treatment options, the surgical technique for the implant you see over on the right-hand side of the screen, and then some of the outcomes and complications, and hopefully provide a summary that you can take home for today. So start with the anatomy of the distal radial ulnar joint. It's very complex. I kind of like this picture. I really searched around for quite a few of them to put into the talk today, and I like this picture a lot as it shows all the stabilizers, the secondary stabilizers, the primary stabilizers of the DRUJ. The first thing to know is it's made of the articulation and the sigmoid notch of the radius with the radial side of the ulnar head. It's supported by the TFCC, our favorite friend, which includes the disc and the ECU tendon sheath. And then, really importantly, these volar and dorsal radial ulnar ligaments that really provide a lot of the stability for the joint. And you can see on this image here both the dorsal and volar ligaments kind of surrounding the TFCC. Also supported by dynamic stabilizers such as pronator quadratus and the joint capsule itself. I actually did a DRUJ cyst excision today where I came volar and released the capsule. And it was quite an interesting approach and allowed me to see this in more detail today. So really importantly, understanding the function of the DRUJ, I think this is why this is such a problem. So it's a unique structure in and of itself, and it doesn't work alone. It's got the proximal radial ulnar joint up by the elbow, and also the interosseous membrane. And you can almost think of the forearm as having three joints: the proximal radial ulnar joint, the distal radial ulnar joint, and then the interosseous membrane. And the interosseous membrane can kind of act as a joint in and of itself as it rotates. It doesn't have a lot of movement, but the force is transmitted through it, and the bones change in orientation to one another, and there's laxity and tightness in different components of the interosseous membrane as the forearm is rotating. As you can see from these images that I have here on the right, it's really the radius that rotates around the ulna. And if you look at the bottom part of this picture down here, you can really see the difference when you're in supination and when you're in pronation, and how important this distal radial ulnar joint is for function of your wrist and as your forearm as a whole. Uh, as most of you know, normal is about 150 to 180 degrees of pronosupination at the wrist. The components of proximal radial ulnar joint and distal radial ulnar joint and how they contribute to wrist rotation. For simplicity's sake, you could say 50-50. I tend to think that more of it comes from the proximal radial ulnar joint. Obviously, you see some issues when there's injury to the distal radial ulnar joint as far as stiffness goes, but I do think more of it actually comes from the proximal radial ulnar joint. As I mentioned, the radius rotates around the ulna, and it's important to understand that, and the stability of these structures is both fibrous or soft tissue as well as bony. So why is this important? There's lots of injuries to the distal radial ulnar joint. I'm sure, fully aware of TFCC tears, everybody's favorite injury. DRUJ instability can be a really complex thing to manage. Obviously, arthritis and trauma are very, very common around the wrist. It can be difficult to treat these things. Ulnar-sided wrist pain is kind of a black box in many ways. But understanding the anatomy from the previous slides can help you diagnose these things quite well. Obviously, we use X-ray, MRI, and CT depending on the nature of what we're evaluating. I also use ultrasound quite a bit in my practice. And things that might interfere with the DRUJ would be a Galeazzi fracture, which you can see on the right, and distal radius malunions. So what is the issue? Why is this an important thing? And as I mentioned in the mechanics on the earlier slide, it's crucial for this pronosupination of the forearm and the load transmission through the elbow and the whole kinetic chain of the upper extremity. It kind of starts to a certain extent at the wrist, and the DRUJ is an important component of it. When you have destruction of the DRUJ from any of the causes listed there, it can really cause a great deal of functional loss and pain. And this last bullet point here is really interesting, is that there's a lot of younger people who are very active, who have had surgeries in the past or have had malunions or Madelung deformity is an example of things that have been done, maybe treated in their youth or even in their young adulthood, and now they're hitting a different stage of life, and they can be really difficult to treat as they go through those years. Importantly, I put trauma, osteoarthritis, rheumatoid arthritis, but congenital deformities can be an issue as well. So first case I'm going to present, and then I'll come back to this later in the talk. This was a 70-year-old gentleman who he's a Army pilot, and in his youth, I think he was in his 30s, he ejected at some really high from his plane, and he hit the cockpit as he was ejecting and had a fairly significant upper extremity injury. He had multiple surgeries over the years and was told there was nothing more he could do. His last surgery was, I think, 20 years ago. But he had multiple surgeries down at the wrist and multiple surgeries up at the elbow. As you can see here, it looked like he had a radial head resection at some point. He clearly had some type of procedure to try and fix his ulna, but clearly is now left with quite an interesting situation. So he presented with both elbow pain, wrist pain, and lack of motion. Second case is a little bit younger. I think she's around 55 years old. She was bit by like a farm animal, either a llama or a donkey or something very strange, about 6 or 7 years prior to presenting to me. She was treated with initially a washout of the injury, then treated with open reduction internal fixation, subsequently went on to some type of necrosis of the distal ulna there and presented to me for ongoing pain, like I said, about 5 years out from the initial injury and initial treatment. And then third case I wanted to present was a younger gentleman. He's in his early 30s, again, a veteran who came to the university. History of multiple hereditary exostosis. You can see underdevelopment or maldevelopment of the distal ulna and the multiple um, osteochondromas over on the ulna there. I have MRIs just to give you snapshots, and I think the central MRI, the coronal T2 there, is quite interesting because you can really see how the TFCC and all the ligaments that connect the ulna to the wrist are very malformed in this case. So I'll get back to it a little bit later, but just something to think about with these three cases. So if we have arthritis or issues with the DRUJ, what are our treatment options? And it's not just for show that I put non-operative first. I really do proceed with non-operative management absolutely first with these. And I talk with people about activity modification and splinting, which they've usually done. But I am pretty quick to go through a series of injections. And as I mentioned, I use ultrasound, so I often am doing a series of ultrasound injections. It can be difficult to determine in this area what's exactly going on. So often I will go through a series of ulnar carpal joint injections, DRUJ injections, ECU tendon sheath injections, or things in the area that I think might be causing their pain, almost or definitely for diagnostic purposes, almost more than treatment purposes. But if we've diagnosed with DRUJ arthritis, there are several known procedures. I've shown two of them here. The DARA procedure on the far right is essentially removal of the ulnar head, and then the Savé-Capongé procedure, which is fusion of the DRUJ, creating essentially a pseudo joint that you can rotate through just proximal to the fusion. There are also several interposition options with hemiresection. Importantly, note that it's a hemiresection, so you actually remove the most radial component of the DRUJ, essentially just removing the arthritis and then sticking something in there to help prevent it. And I've done this probably the most of any procedures. And then obviously an ulnar shortening osteotomy can be used in conjunction with this or sometimes in isolation, depending on the issue. I put this up there because there's lots of interesting things that people have come up with to stick in there. There's posterior interosseous artery flap, ECU, FCU, PQ, and then just to throw Mayo the bone here, the calamari procedure, although this was reported with hemiarthroplasty, but using a allograft meniscus to put in there. And I think that's quite a unique idea. It shows us what hand surgeons are capable of. But probably the number one thing that I wanted to talk about today was arthroplasty for DRUJ, in particular for arthritis. So, what are the indications? And it's kind of interesting because the indications are for primary arthritis, as I mentioned, for which can be rheumatoid, osteo, post-traumatic. But important second bullet point you see there is actually a good indication for these types of procedures, which has failed other procedures. And I would say that I see these quite a bit, a failed DARA or a failed Savé-Capongé. Again, the reasons to do this are to try to restore grip strength, decrease pain, and improve function overall. So Over the years, there have been several types of prosthesis. Orthopedic surgeons are very good at making things up and coming up with prosthesis. So, many years ago, the ulnar head prosthesis was probably our only option. You can see in the upper left there an example of ulnar head prosthesis. This is soft tissue dependent, so it relies on maintaining the soft tissue. So when you do your ulnar head resection for this, you have to be very, very careful. There's also a hemiarthroplasty option, which you can see on the right there. Again, reliant on soft tissue stability. And there's several different types that you can use for that. And then, as I mentioned earlier, showed a picture of earlier, there's also total DRUJ or the aptus prosthesis, which is semi-constrained and modular. And I'll talk a little bit more about that. You can see the image on the bottom right there. There are several options. There's ceramic heads and metallic heads, depending on the situation. So why do these things matter? What implant you choose, and just like all of the things we've learned about mechanics throughout our times with hips and knees and any even elbows, everything that we know about arthroplasty, there are differences in constrained and semi-constrained or unconstrained, and it really is stability and versus complexity. There are several known complications with the ulnar head implants and the risk of, so the ulnar head only implants, the risk of erosion of the sigmoid notch. Several studies have shown pretty good survival of these things with good mechanics as long as your soft tissue is in place. The pyrocarbon, which was an option, does have good elasticity with good wear properties or better wear properties. But the aptus semi-constrained, at least on many of the studies that have come out over the last decade or so, is improved stability with strength, lifting, and improved rotation. And this is an image I just took from the aptus guide here of somebody holding 20 pounds. And I think this is a reasonable expectation with the prosthesis if things go well. So I just thought I'd get into a little bit. Here's the basics of the surgical technique for the DRUJ, and I'll go into just a touch more detail on each thing. But essentially, it's a dorsal approach through the ECU or through the fifth dorsal compartment. You extend over volarly to create a flap of your extensor retinaculum. You resect the ulnar head. You do a smooth peg fixation of the radial plate with some screws to hold it in place, intramedullary ulnar stem, polyethylene ball, and then importantly, you start range of motion very quickly. And this is the aptus semi-constrained prosthesis in a nutshell. So the basics of it. So just to go over a little more detail, here's the exposure, as I briefly mentioned, a true ulnar-sided approach over ECU. You do a flap elevation, as you can see up in the upper right-hand corner, moving part of the extensor retinaculum. That allows you to see the ulnar head. You release ECU in its entirety to give you a good view of everything, and then move on to your ulnar head excision. You start about 2 centimeters down. It says maintain TFCC if possible. I would say that that's a little bit difficult. You can see that this idealized schematic here, it looks like they've lifted off the TFCC, but it can be very, very difficult in these cases to save the soft tissue. I do spend a lot of time usually dissecting with a knife to preserve as much as possible, really coming off the bone, but it can be very difficult, especially in post-traumatic cases. Trial plate positioning, very important. If you look at the upper right-hand schematic there, you want to place the plate volarly on the radius. And for those of you who haven't never done this, this is a unique approach to the radius. We don't often look at the ulnar side of the radius, but it has pretty unique anatomy. And if you look at the row that's labeled B there with a big X at the end, you see how the plate wants to sit in this, kind of tilted position, and that's really what you want to avoid. So in some cases, you'll have to actually kind of contour the ulnar side of the radius there to get the plate to sit nicely. So oftentimes it's a little bit volar than central, although central can be okay. So once you've got this contoured or once you've got it where you think you want it, you can put some K-wires in to kind of hold things and make sure that you like the positioning, verify it on fluoroscopy. You see this maintain the 3 millimeter gap to the lunate fossa, which you can see on this lower fluoroscopy shot here. And once you've got everything in line, you actually drill through the radial plate, the most distal portion of the radial plate, for your peg hole, which you can see in this right image on the right, the smooth peg at the top of the implant. Um, you know, basically, this is standard orthopedics at this stage. Once you have everything in line, drill and fill, you put screws across everything. If you look at this, one of the technical aspects of it is that only one of your screws is bicortical. So there's actually longer plates than this, but if you look at the image on the right, only that second screw is bicortical. None of the other screws are designed to be bicortical. And it's always scared me just a little bit that it's going to come loose. It never has, but it scares me a little bit. The reason being, you do on the radial side, obviously of the radius, there's several structures there. Brachioradialis is inserting there. If you were off a little bit and came out, you could irritate a lot of the tendons in the first dorsal compartment. So just trying to be careful not to irritate any of the structures on the radial side of the radius. Um, yeah, once you've got that in place, you move on to the ulnar preparation. You place a guide. If you look in the upper schematic there, you can see this long, slender kind of device here that's got the ball on it, and that sizes where you're going to, if you need to cut your ulna more distal. So we started with a 2 centimeter cut. Now, in many of the cases that I've done, there's just no distal ulna, or there's a lot of pathology, or something's wrong. So I end up having to cut more of the ulna to get things to fit. And this guide will help you determine how much you need to fit. Then you just simply drill and ream, just like we would, to the size that fits the stem that you're going to place. And there are several sizes available. You insert the stem in a standard fashion. You don't want to insert it too far because it can propagate a fracture. I've never had that happen, but I've been scared on several occasions. And if you look at these images in the bottom aspect here, you can see the differences in the stem itself. It's coded here for ingrowth, but you can see the length that you can have 2 centimeters all the way to 4 centimeters. And I should mention that there are custom implants, which I have been tempted to use multiple times, but have never actually done as of yet. So once you've got everything in place, you place the polyethylene ball. You then lock it in place, or you put the radial slide cover over. I don't screw it down. I always test it, make sure everything's good. And then, as it said here, back it out and reassess. I almost always do that just to make sure that nothing is really getting in the way. And then I torque it down and tighten it with a screw, and that is that. So that is done. I will say you should always test these things. I've been lucky. I feel that if you get this in a good position, you can really get good range of motion, coming close to functional range of motion, about 150 or 160 degrees, 80 degrees of pronation and supination each direction. So what are the clinical outcomes of this aptus arthroplasty? This is one of mine that I showed you earlier. So it's done pretty well. VAS scores decrease, the Mayo risk score improvements, grip strength is restored, forearm rotation is quite good in both pronation and supination. And patient satisfaction. In orthopedics, we want things to be 90, 95%, but honestly, 70, 80% is pretty good. There are, however, some complications and concerns. There's high rates of complications reported. The reported complications are variable. They can range from ECU tendonitis, obviously infection, malposition, and loosening would be major ones. And the revision rate is cited as high as 40%, as low as 20%. Should note that revision is very difficult and there's no textbook on it. So if you elect to do this, you should be, thoughtful about what you might do if it doesn't work. There is an interesting study that I've noted here at the bottom. I just came across in preparation for this that showed, high revision risk in low center volume or low volume centers. And I've always found these types of studies interesting because it's, this is a surgery that is essentially going to be low volume because there's not a ton of indication for it. So I don't know how we really want to approach these things. I think you should be a experienced surgeon to do it, but you don't have to do dozens of these per year, I think, to do it. And you can see that this is again one of my cases on the right here where there's a lot of osteolysis and lucency of the stem going on here. So whenever we don't know what to do, when Eric and I remember when we were in residency, there was always a systematic review or meta-analysis every week, it seemed, on something. So there have been several about this. Good survival, kind of high complications. There's a lot of longevity in these constrained implants if things go well. I found this interesting in the reviews is the underreporting of complications. And I think in surgeries like this, where they're kind of rare indications and we're not doing high volumes in total, I do think underreporting is very, very common. So approaching about 30 minutes here, I'll just give a summary. So DRUJ arthroplasty, it improves motion, pain, quality of life in your patients if you select them correctly. I think the Aptus prosthesis has come across as a very good option. Knowing when to use it can be difficult. It is very good in failed procedures, and that's where I've used it a lot. As I mentioned, patient selection, surgical expertise is important. Always throw in the standard further research is needed, but I think that this is truly one area. If you looked at every paper published on this, which I tried to do in preparation for this, most of it is there's some pretty good studies, but none of them are excellent because we just haven't been doing this for very long and we don't have great numbers. So, just to kind of end the talk with going back to my cases here. So, if you remember, this was the Army pilot who many decades ago, I think 4 decades ago, injured in his plane, had bad elbow injury, bad wrist injury with multiple procedures. So when he came, the first thing I did was kind of start over, ask him what his primary issues were. His primary issue was with his wrist. He couldn't turn it over. It was painful every time he tried to rotate. I asked him if there was one thing I could do, what would it be? And he said, take care of my wrist. So we decided to move forward with treating his wrist first with the understanding that we would come back and deal with the elbow later if everything went as planned. So I went ahead and indicated him for the DRUJ semi-constrained aptus prosthesis. You can see these are my intraoperative photos. I was fortunate enough to actually take an intraoperative photo on this one, or I think my fellow did because she was pretty excited about it. Surgery went very well. Positioning of the plate went very well, and he was very excited. He is now, I think, a year and a half out, and I asked him to send me some videos to show you guys. So I think he's gonna do it. So. You can see his rotation isn't quite full, but it's pretty good. And this is where he was at the last visit radiographically. One thing to note, just looking at the radiograph here, you can see that the ulnar bowing is a bit of an issue in these long stems. So just something to be mindful of if you have some abnormal anatomy. This case too, so this was the woman who was, like I said, it was either a donkey or a llama or some strange farm animal that bit her many years ago. So when she first came to me, the story was really weird. I didn't know exactly what was going on. My first thoughts were, let's rule out infection, which is what we always want to do. So I went through the whole process. I got an aspiration, basic labs, no concern for infection. She hadn't had any issues with this for multiple years, 3 or 4 years. So I believe that there was no infection ongoing. If you look at the T1 weighted axial cut over here, you can notice that her ECU tendon is really large. So she had some other pathology associated with this as well. Nonetheless, I elected to go forward with the Aptus semi-constrained prosthesis, and this is the one I wanted to show you how things can go wrong sometimes. It went beautifully intraoperatively, and for 6 months, she was so thankful. She literally said all the great things. You changed my life. I can't believe all of this. And then one day she was doing something gardening and she felt like a snap or a pop and just never recovered from that. So I saw her back in clinic. There was some osteolysis on plain films. I kind of watched it for a little while, maybe a few weeks, had her come back again. became pretty concerned that there was an ongoing infection given this history of domestic animal bite. So I indicated her for hardware removal and placement of antibiotic spacer. Again, I did the whole workup. There was no indication of infection, but given this history, I was concerned about that. I went in, took the stem out. The stem was definitely loose. It was basically pistoning back and forth. The radial plate was not loose at all and was adhering to the bone quite well. Nonetheless, I removed it all. You can see this antibiotic dowel in here. And one of the reasons I wanted to bring up this case was I had planned, gosh, I think it's now about 6 months ago, to do a reimplantation. She never grew anything on culture. There was no evidence that she was infected. She just had seemingly osteolysis. So I was planning to reimplant her and talked with the company a lot about how do I do this? You can't read the guidebook on this. And their recommendation is for bone graft and placement with bone graft in there. I kind of thought I was just going to do cement. It made more sense to me to cement it in, maybe with some bone graft too, but I was planning to cement it. Nonetheless, she had a heart attack, and so I haven't been able to do that for her. So I'm still planning on probably cementing it back in when I get a chance. And then the third case here, so this is a younger gentleman with MHE. Same kind of issue as that first case that I had gone over with you. In addition to MRI, I get dynamic ultrasounds of all these to show the impingement in the distal radius there. So basically, what's happening is that every time he rotates, the ulna is impinging or hitting the radius in an abnormal way and causing pain. Now, I did an injection too, a diagnostic injection, and it didn't really work. I injected the DRUJ, I injected the radiocarpal joint, and it didn't work for him. So I discussed with him that this is a very complex situation. I don't know exactly what the best thing to do, but I did not do a DRUJ arthroplasty for this. I ended up doing essentially a DARA procedure. I removed more of the distal ulna and the most prominent osteochondromas, and then did stabilization of the distal ulna using ECU tendon. You can also note on his ulna, because of how it's malformed, I don't think he would be a good candidate for an arthroplasty because I'm not sure that I could get the straight stem down. This is one, however, if he doesn't do well, that I would consider, talking to the company and seeing if we could get a custom prosthesis. So hopefully those cases kind of solidify some of the things I talked about and the thought process behind these things. Bottom line with all this is that it's an interesting surgery. It has good outcomes when you can do it well. And I guess over the years, I've become more comfortable with it. I don't think I've expanded my indications, but I've thought about it several times and thought that there are some indications for this, and in certain circumstances, maybe wished I would have used it for certain people. So, anyways, that's it. I want to thank you all for having me. If you have any questions, please get a hold of me. If there's any residents, this is my email here, Joseph-V Buckwalter at uiowa.edu. Please get a hold of me if you ever have any questions about anything or you want to come visit us in Iowa. You're more than welcome to. I think that's it. So I'll end the slide.
Awesome, man. Thank you very much.
Yeah, I'll
That
try and
was
stop sharing. I don't know if I can do that.
fantastic and great cases.
Yeah.
So I
Okay.
want to open this up to questions that that's on.
Thank you, Dr. Buckwalter. That was phenomenal and a wonderful, wonderful talk. I had a question. You also mentioned that you do a fair number of hemiresections. How do
Mhm.
you decide between the aptus, the hemiresection, and then are there particular indications for each?
Well, as I mentioned just at the end, I think that when I first got into practice, I was most comfortable with hemiresection. So I did a lot of those and it felt comfortable. It was a fairly, I don't want to say easy procedure, but it's something about it seemed to make more sense to me that this was something I could do fairly easily. It was for standard, I would say, isolated DRUJ arthritis. I felt that was a very good, if you didn't have radiocarpal arthritis, you didn't have any of those other things that I showed in those cases. For standard DRUJ arthritis, I still feel like hemiresection with interposition is a very good option. I think more with the Aptus with the DRUJ arthroplasty, it's more of these, I'll just say strange or weird things that you come across. They have more complexity to them. And you're really trying to maintain, there has to be some component of instability. And the constrained nature of this or semi-constrained nature of it allows you to restore that. So I think that that is the primary thing. That said, I will say that I've seen these conditions recently where or maybe over the last couple of years, where I think maybe this would be a good option, even for something simple like, again, the standard DREJ arthritis that I'm not able to treat well with the hemiresection. And I can always come back and do an aptus later if I want to, or a checker later if I want to. So, again, I hope that answers the question. It's been an evolution not only in how I think about these things, but I think in my practice and comfort level with it as well.
When you do the Henry section, do you interpose or stabilizer, or do you just resect?
So nowadays I just stabilize. So it depends on how I stabilize it too. I've also changed that. I used to use ECU primarily for stabilizing. I have recently done a few tight ropes. I don't know if you guys have done that. Use the Arthrex tight rope with fairly good results, with the exception being hardware prominence being the real issue with that is that people really feel the buttons both radially and ulnarly. But for as far as stability goes, it seems to work fairly well. But initially, I would just interpose kind of whatever I was thinking and then move to stabilization with ECU. Like I said, over the last, I don't know, maybe a couple of years or so, I've tried a few tight ropes. I did do, I think I had a couple of people early where I just did hemiresections and they did very well without any interposition or anything else. But they rely very specifically on not disrupting any of those stabilizers on the ulnar side of the wrist. So you got to just make sure your takedown is very careful that you don't disrupt any of the ulnar carpal ligaments or anything over on the ulnar side of the wrist.
Any other question?
I have a question.
Yeah.
So I'm one of the attendings. I work mainly at the trauma center, and so I see like a combination of, DRUJ arthritis and instability in patients that have distal radius malunions. And they're
Mhm.
not like bothered by the distal radius malunion, but their DRUJ hurts. So have you used this for that indication? Are you trying to like where do you put the implant? Are you doing an osteotomy first? What are your thoughts?
I almost always would do a distal radius osteotomy first. I mean, if it's the DRUJ or like you said, they're not bothered by the position of their wrist, but they're bothered by the instability of the ulna. I always start with the radius osteotomy and then deal with the ulna secondly. So again, I'm doing two of these coming up here where I'll do an osteotomy. Usually it's an opening wedge osteotomy. I'll use either iliac crest autograft or allograft, depending on what the patient wants, but I'll do a three-dimensional osteotomy to try to really correct or restore the articular surface of the radiocarpal joint. But the secondary benefit of that is you can usually restore the DRUJ to a certain extent. If they're still ulnar positive or something, I'll do an ulnar shortening osteotomy in conjunction with it. I have not done a DRUJ arthroplasty in conjunction with a radial osteotomy. It's certainly an option, depending on, if they're I have several where we, missed a Galeazzi or something happened and the ulna was out chronically for a long period of time. And that might be one where, you kind of pull the trigger on that a little bit earlier. If you had a distal radius malunion in a Galeazzi, do both things at once because that'll give you all the stability you need is do the radius osteotomy with the DREJ. But I
Yeah.
can't say that I've done it. So.
Gotcha. I mean, so obviously, if there's no DRJ arthritis or chronic dislocation, do the osteotomy, right? For the
Yep.
trainees, right? You're always addressing the radius malunion if there's DRJ instability. But in the setting of also having like the DRJ totally blown, you have to, do something for their obvious DRJ pain. What do you think the advantage of doing a distal radius osteotomy is? Do you think that it puts like less stress across the implant, the semi-constrained implant? Like, why do you think you need to do that?
And again, I don't know what the malunion looks like. So I mean, I'm assuming it's some extended 40 degrees or something. I don't know how off it is. I just think getting the more anatomic parameters of the radiocarpal joint long term will be beneficial for pain and probably range of motion. You don't necessarily have to do it. I appreciate that sentiment, but I think if you can get normal anatomy back to the radiocarpal joint, it'll preserve both of those joints, whatever you decide to do with the DRUJ long term better. So, again, that's just my philosophy is like if we get the radiocarpal joint at least as close to normal as possible, because I imagine most of the ones you're talking about are pretty off. I don't know. I mean, I'm not talking about 10 degrees, but usually they're pretty substantial. So I like to at least get them somewhere close to the normal parameters.
Okay, thank you.
Mhm.
Perfect. I guess I have a question for you. I have to say I like love the Aptus, and I actually like the results I saw a lot in my fellowship. But I've had trouble indicating people as I feel like maybe kind of as you mentioned some of the other options, whether it's stabilization alone, if it's just like a DRD reconstruction alone, if it's this if it's no arthritis or like the NSK or some of the interventions are appealing because most of the times I'm seeing stuff that I feel like those are reasonable options that have not been blown, and that like the Aptus at least for me has been really like a salvage of a failed like SK or failed DARA. That being said, I keep trying to convince myself, and I even actually presented a case to our Wednesday morning conference, trying to convince my colleague to allow to convince me to do an aptus not in the setting of a failed DARA or failed Zev. And you showed some nice examples of that. But what are your thoughts? Like, should I? I talked to Hank Kurt in Amsterdam. Talked to some of my colleagues at Mayo and others. And that there are definitely lots of people doing these not just for like the failed salvage procedures. Whereas, like, I feel like that's my indication at the moment, but I just haven't pulled the trigger and pushing that indication. What are your thoughts on that? Should we be doing more? Like, Hank swears to me he puts in like 40, 50 a year, which seems crazy. I don't know how he's seen that much DOJ problems, but he has to be doing them in like relatively primary settings instead of things like DARAs and SKs and that type of stuff. But I mean, should we be putting them more? You showed a very good example of what can go wrong. That being
Yeah.
said, like looking at the Mayo series, I mean, they have a large percentage of patients that don't go wrong and do pretty well.
Yeah, everything you said is everything I've thought over the last few years. I mean, I think as I mentioned earlier, there's an evolution in practice of each individual as they go through this. I think the few times, if you start with the few times you do it and you have good results and you get comfortable with it, then I think your indications start to open up just a touch for this. And I do think there's room to start thinking about this for lesser indications than the failed DARAs and all of those. I think there's room for it. I don't know if I'm quite there yet either. And as I mentioned, I do prefer hemiresection and some other options first for primary DRUJ arthritis. I can't, it just seems like such a big surgery for such a small problem. And that's a
Yeah.
philosophical approach. But, I think there's room for it. And I think the
Yeah.
more we get, I tend to be literature driven. And as you mentioned, there are some very good studies out there that show that this can be successful. It may be more successful in people with less pathology too. That's
Yeah.
something that we always struggle with because again, the people I tend to be doing this on have had bad issues. So their
Yeah.
pathology, everything, it's just a little more complicated overall. But I do think there's a role for it. I'm probably a little further along than you are with that, but I went through that stage too. And I guess I would just say, find that one indication, do it, see what you think, and then see if you start opening up to that.
So I
Yeah.
feel like what you guys just said is very similar when Alex Shin came to talk to us about fragment specific plating for distal radius fractures. And he was like, look, if you only do it on the really, really hard ones, it's going to be really hard when you do it and you're not going to be super satisfied that you did it. But if you open up your indications and you do it on even the simple ones or some of the other stuff, you get better at it and you'll notice that it does well. It's kind of like everything else. I just feel like Wags, I feel like we've gotten so good at the Berger Adams stuff that we've done that our outcomes have been relatively really good for our instability cases. That, once you've gotten good at that, now you're like, well, I've saved them a major metal implant. And so now you're really reserving this just for the people that have had a prior resection with associated instability. And the truth is, we just don't see a ton of it, right?
Yeah.
I mean, most of the time we're pretty thoughtful on who we indicate for what we do as far as um, an SK or a DARA. And, a lot of those times it's like someone who had RA that we fuse that would then do a DARA,
Yeah.
or something like that, So it's like, I don't know. I still haven't really had some. I mean, we had like one person WAG that I thought that we had like signed up for this, one or two,
Yeah.
but it's always like I feel like it's minimal. I'll tell you, I feel like the DRUJ is one of the more frustrating joints to deal with. And maybe it's just because I still don't understand it well. I don't know, but I did an ulnar shortening osteotomy on a 14-year-old on Friday who had like a prior distal radius fracture, slightly ulnar positive because her radial side had growth rest, but like no deformity to the DRUJ. Did it with the fellow. X-rays looked perfect. We shortened her by 4 millimeters. And I honestly don't even know what made me check it. The X-rays looked absolutely perfect. And at the end of the case, I was like, I'm just going to check her DRJ, see how it looks. She had a large central tear. And sure enough, at the end of pronation, she has a slight clunk.
Hmm.
And of course, my fellow looks at me, he's like, gotcha, what do we do? I'm like, I don't know. I was like, it's like, hope and prayer during a surgery is not a good option. We're like, hey, I hope this is going to go well after it's done. But technically speaking, we essentially put her in slight supination for a period of time after the surgery, and I figured like, all right, we'll let her sit there for 3 to 4 weeks. But I think it's just because maybe we over tightened her. I don't know. I mean, she had a large central tear. So it's possible like there's some TFCC issues that are causing some sort of instability. But I mean, she was definitely ulnar. She had ulnar impaction syndrome on the MRI, and the scope matched it. I don't know. As I said, I find these super frustrating because it wasn't a bony issue. Her IOM was technically okay. Maybe it's a TFCC thing, but yet again, it could be ECU. This is where it's like have to go through all the various structures, like the four-leaf clover thing, and even when you think it's one or two, it's like, oh, or it's number three.
Yeah.
And it's just, I don't know. This stuff always scared me because it's like once this goes bad, then I say, well, what's your next step?
You mean once
With an
the
Aptus, yeah.
yeah. Well, I mean, as I showed there, I mean, I'm not sure. There's no textbook on how do you redo this. I mean, even in talking to the company trying to figure this out, there is really no good guides on this. So, maybe reserving it for people that really have bad problems to start with, because you essentially leave them with the DARA afterwards. I
Have
mean,
you seen their PRUJ implant that they're coming out with?
I have not.
It's actually pretty neat. It's a very similar type of implant for essentially an Essex Lopresti type injury
Mhm.
where someone's missing their radial head. And essentially,
Hmm.
it's got an implant that fits into the ulna with a small stem up. Well, as you and I, we were supposed to be one of their sites for potential, but I don't know if they ever got past the FDA part. But it's very similar. Pretty
Yeah.
neat. I mean, Shecker and them are very smart people. When they came to give us a talk, it was incredible to watch. I mean, look, your X-rays look perfect. That's why I tell everybody, it's like even when you do fantastic surgery, stuff can happen. It looked perfect, perfect.
Yeah, I mean, it's interesting just talking about this stuff. I mean, that's kind of why I chose this as a topic because it is complicated and I don't know if there's answers. And I think I always remember Gelberman telling me this is what you do. You pick things that are difficult and nobody knows what the real answer is, and you talk about those things because, it's just nice to know that everybody's kind of in the same boat. I don't think that there is an answer to any of this. I think this should be something people start to explore and see if it's an option for them. But like I said, I would start with the very, bad cases and see what you think.
Have you done any denervations, like ulnar-sided denervations or full wrist denervations for this stuff, or not really?
I almost with if I did this procedure, I would denervate. But that is also again talk about evolution. Sanj Kakar, one time I saw him in Florida somewhere, and he just said, "Oh, I denervate all wrists all the time." And I don't know if it's true or not, but I was not a big denervation person at all. And then with some of these bad cases, I've started doing that. And again, I don't know if it's really making a difference. I certainly think that there might be something to it. So I've started doing this with bigger cases. I do not do it routinely. I do not offer it in isolation, but in big cases where people have had chronic wrist pain or a lot of issues, I will add that to the procedure.
Yeah, it's interesting. I mean, denervation, Yeah, it's interesting, Tom, to that. At Mayo, Berger technically was denervating just the really mild arthritis. And when you look at his outcomes with that, that's where like the papers came from, is it wasn't like the advanced like stage four or the advanced like disasters. It was like mild arthritis he would denervate. And then it does seem like it's been expanded significantly. I will be frank, I've gone the opposite. I started denervating a ton because it made a lot of
Mhm.
sense to me, and I was like, oh, this works. And then I saw many cases that did not work at all. And even though they were like classic in the middle, started doing arthroscopic radiosilectomies because maybe that was the problem. I don't know. I mean, I think denervation can have a role, but I've become much less of a fan of it as I practice longer because I personally think it's a bit of it's a little bit of sports magic PRP nonsense, I think, and like psyching patients into you're doing something to help them. Gottschalk will disagree with me on this, but like I think it's a bit of a psychological thing rather than an actual like real answer. Now I do it, so I can't say that I don't do it, but I have definitely decreased the number of people I indicate it for because I just am not as much of a believer in it.
The funny thing is, Wags, that I actually can't remember the last one I've done. And I don't know if it's because I just haven't seen the right patient in a while, but I had pretty selective criteria for a lot of them where it was, they had to really just have central wrist pain, no radial sided pain, no ulnar sided pain, and kind of just central. But I haven't had someone in a while. And if I was really like on the fence, I would normally try and do a block on them, although you could argue like I wasn't doing ultrasound guided, so I could have been knocking out other nerves. But I've had good success, but I've also had a fair number of people that failed where it's like, look, it didn't help them. They had stuff. But I mean, you and I both know I use it adjunctively for almost
Yeah,
any wrist fusion, any four corner fusion, PRC, anything like that, they're getting denervated by me.
sure.
But I just do partial denervations. I've seen two or three ulnar sided denervations by one of our community colleagues who's probably one of the best surgeons that I've ever seen operate, who's incredible. And both of the people that I've seen that he sent as like second opinions to me, I always am like, they had like some numbness in the ulnar distribution after doing like the ulnar sided denervation and some other stuff. And so I'm just like, okay, maybe that's not a good, that's just not one of the better ones, right? Whereas I'm intrigued by the thumb one, obviously,
Mhm.
but I don't know. I'm a slow adopter. Wagner knows this. I'm a slow adopter of a lot of things until he has to
Yeah.
do it and show me that it works. And then I'm like, all right, fine, I'll do it.
I don't know. The one that seems extreme. I have seen one patient from one of our people in our fellowship, that private group in our fellowship that did the thumb one, got a SBR neuroma, I'm pretty sure, from the thumb denervation. I don't know if Greaves on, but I sent him to Grieve. I'm curious what Grieve did with him. I don't say Grieve on. But I sent him to one of our partners to see if they agreed. But we even tried injecting it, got better. I'm pretty sure he created an SBR neuroma by doing a thumb denervation. I definitely don't think it's like that's. I think the wrist one is perfectly harmless. Like I've never seen actual real complication from it. I definitely am not sure all the other ones, or at least the thumb one, and sounds like the only one are totally harmless, which you do worry a little bit about. But anyways, well, this is great, very controversial as you can tell, Jody. But I we appreciate you doing this. This is DRJ is a fun topic because it's so controversial and
I don't know
difficult.
if it's fun, but interesting. I'll say that.
Yeah, for sure,
I don't know.
for sure.
I haven't denervated a thumb. I'm not a believer as of yet.
Yeah.
So
Yeah, I'm not sure if I'm jumping on those board that
I
bandwagon
also,
either.
I do use ultrasound quite a bit. So if I'm going to do an isolated denervation, I will definitely have an ultrasound guided block prior to that.
Yeah,
Lidocaine only, check it, make sure that it's going to be the right thing. And we have like full-time ultrasonographers who do all that for us. They'll do nerve mapping and everything to like line it all up.
that's
So I mean, if
awesome.
I wanted to do some of the denervation in the thumb, I'm sure I could. I'm not a believer.
Yeah, for
And
sure.
despite this talk, the truth is I'm kind of a slow adapter too. I over time started finding indications and think that this is, a reasonable thing to have in your armamentarium.
I
Yeah,
thought
for
your
sure.
indications were really good on these. Meaning, I
Yeah,
didn't, I didn't, I actually didn't disagree with any of the stuff that you did. I thought your indications were spot on for what you did on them for very tough problems.
Yeah.
I mean, I thought it was. I mean, if I was going to do them in anyone, I thought what you picked would have been very reasonable.
Yeah, I have some other ones that are, yeah, I would, I could have pulled a few. I could have pulled some was where I didn't do it, which I wish I would have. Those are the kind of the weird ones where I did something else and I have retrospectively wished that I had considered this and subsequently talked about it, but they're doing okay. They're just not doing great. And so
So,
wondered if I added this or if I had gone with a constrained prosthesis, would I improve the range of motion without pain?
it's interesting. You showed someone with MHE. The only MHE patients I've ended up doing had like, I think it was like type 4 or whatever it is, where essentially they almost have like a fused, like they have a synostosis almost kind of type of thing, way more proximal in the form that I've actually just put screws across, almost like an SK where I've just fused the DRUJ because essentially they have a
Hmm.
one bone forearm to start. So it was kind of interesting. I think I've done two or three of those over the course of my, decade career, but it's the ones with the deformities are the really hard ones because then you're trying to figure out what exactly you're going to do. And I think your idea of starting on the radial side first often makes a lot of sense because sometimes you can really correct it back to normal, which just offloads the joint just enough to where they don't have symptoms.
I mean, that has been my experience is that you deal with the radius and figure out everything else later.
Yeah, and Eric and I discussed that. That's a tough one because at some point there's an age cutoff, right, where you switch from thinking of a radial osteotomy to an ulnar shortening or a DERA type of thing where you're trying to figure out what you're going to do. And it's not always super easy to decide. I guess if the patient's 20, it's very simple, right? You're going to go do something for their radius as opposed to their ulna. But as you get into the 60s or 70s and these people come in with these really nasty distal radius malunions that theoretically all the articles tell you they're going to do just fine, but they're not doing just fine. And
Yeah.
then it's like, are you really just going to go do a dare on these people?
Yeah.
That's that. Those are the ones where that's what everyone tells you to do. But I don't know.
Well, Eric brought up that there's always psychology to these patients, but a lot of them say that it hurts, when they're 65, 70 plus with those malunions. A lot of them really don't like the way that it looks either. So, there's something psychological about it. And if you do address the radius, you can usually correct the, aesthetic appearance of the wrist. And again, not that I'm doing that commonly, but several occasions I have, and again, seemingly people are doing very well with that. So I kind of again have a philosophy deal with the radius first, even in those circumstances.
I don't know how much, I guess we're almost at time. So when you do you said you do opening wedges on all of them. Do you typically go volar for all these? Do you do any dorsal?
Always go dorsal. I mean, it depends on the deformity, but I almost always
Okay,
go dorsal.
you don't even need to say anything more than that. That's perfectly aligned.
Yeah.
I'm the dorsal person as well. That's why I laugh because everyone else seems to be volar most of the
No,
time.
I love going dorsal. I tell my residents, you won't get an experience. You got to learn how to operate on the dorsal side of the wrist. Yeah.
Depending on the deformity, gotcha. Depending on the
Well, it
deformity,
is
as we
depending on the
talked about.
deformity, but you can do a lot from dorsal that I don't think you can do from
You
volar.
can. I mean, dorsal has the advantage of not. So volar has the issue with the EPL if you go to correct too big of a deformity.
Mhm.
But I do think. I mean, if you want to talk about evidence, there's more evidence to support going volarly with lower complication rates for the lesser deformities, and that was an article that just came out. So that's a very updated systematic review. So look, Gottschalk and I debate this all the time, but I think for the right patient, dorsal works great for the bigger deformities because you don't want to push it because you can get APL ruptures. But I do
Yeah.
think smaller deformities you should do volar because I think you just have less complications. We could talk about that later. I'm also not a fragment specific person. So I'm much more of a volar plus ridge than versus doing like a 360 fragment specific. So maybe it's just a velocity two thing too.
Yeah.
And Scott likes to bring up controversial topics in front of people and try to prove his point. So that's
Well,
basically what
I'm
that
glad I
was,
made
just so
him.
you
I'm
know.
glad I made him
So
happy.
you fed
I didn't
right
even,
into
all I
his
did was ask him if he went volar
you
or
fed
dorsal,
right
and he
into
said he did
his
osteotomies. That's it.
I almost
For the
always go
record, and it
dorsal.
is being recorded
Yeah,
for the record.
almost always go dorsal. I mean, I love volar plates too. I just put together this absolutely terrible wrist that everybody said I had no business fixing, and I did I fixed it. I mean, I actually like fixing, so sometimes I will use fragment specific fixation. I mean, I will try and fix the things that are really disastrous because I have also found that if you do like a bridge plate or you do something else or leave them in an X fix, I think if you can fix it, you can get it close enough, it'll be better. It'll heal at least in some semblance of a wrist, and giving them, you're trying for pain-free, reasonable range of motion. Anyway, so I take my chances trying to fix things, even though I'm very scared it'll all fall apart many times. But
Yeah. Eric and I have gone to doing a lot of hybrid fixation. They're doing both a volar plate, getting it pretty darn close, and then just offloading it
Backing it up with a bridge player
with
for
a
like 8
dorsal.
weeks. Yeah.
well, that's essentially what I did. I did a volar plate. I got everything, but the whole dorsal aspect was sheared off. So I got the volar plate essentially buttressing and put the shortest locking screws I could so that it wouldn't push anything down because there was nothing for them to fix into. So I only had shaft screws and then just locking screws in the head of the plate and even the locking screws in the distal shaft. And then I went dorsal and I put everything back on top and then used dorsal plates to push everything back down. So it's a lot of work, but it went quite well.
Yeah, I feel like they've debunked, the whole sandwich issue type of thing. Remember they used to call it a dead bone sandwich type of stuff. I feel
Yeah.
like that's been debunked now.
I mean, there was soft tissue attached to everything. It was just sheared off. And again, although I restored the whole volar cortex and it looked beautiful, just like a normal distal radius would, everything was sheared off and pulled proximally. So I had to bring it back, and there's no way I could have done it volarly. I don't think I could have put it back with a bridge plate without opening it up. So once I'd opened it up and I was looking at everything, I just put plates on. Yeah, anyways, fun. Orthopedic surgery is fun.
It is.
Yeah.
All right. Thank you very much.
Yeah,
Appreciate
my
everybody
pleasure.
hanging out and look forward to seeing you soon.
Yeah, of course. Well, this was pretty cool. Thank you so much for inviting me. And again, if you have any questions, please let me know. You all are always welcome in Iowa, so come anytime.
Awesome, man. Enjoy your new facility.
All right, take care.
Bye.